Hi, my name is Jordan Angeloni. I am presenting Unit 4 Case Connections presentations, and I will be presenting Case 2 and 4. In Scenario 1, a full-time female infant, 9 days old, is diagnosed with elevated levels of branched-chain amino acids, which is highly indicative of maple syrup urine disease, MSUD. Given her family's history, MSUD is an autosomal recessive metabolic disorder caused by a deficiency in the branched-chain alpha-ketoacid dehydrogenase complex. This is a critical multi-enzyme complex needed to degrade lysine, isolysine, and valine, which are branched-chain amino acids due to their carbon R group structure. In individuals with this enzymatic deficiency, these specific amino acids cannot be properly catabolized, causing them to build up into toxic metabolites such as branched-chain alpha-ketoacids in the blood and urine. This can result in severe neurological damage, poor feeding, vomiting, and potential life-threatening encephalopathy. Continuing on with Case 2, essential amino acids. Leucine, isoleucine, and valine remain essential amino acids in MSUD, and these amino acids are needed for proper muscle growth, blood sugar regulation, and energy metabolism in certain conditions. However, due to the underlying enzyme deficiency, precise dietary management is needed to regulate their levels and prevent toxicity. Potential vitamin supplements, such as thiamine, vitamin B1, acts as a cofactor for the branched-chain alpha-ketoacid dehydrogenase complex and may be beneficial in certain milder thiamine-responsive variants of MSUD. Thiamine supplementation can help maximize any residual enzyme function, thereby enhancing the catabolism of branched-chain amino acids and mitigating their toxic accumulation. Scenario 2. A 69-year-old woman with a long-standing history of joint pain and distinctive blue-gray pigmentation of the ears and sclera is likely suffering from alkaptonuria. This is a disorder due to the deficiency in homogentisate oxidase, an enzyme involved in the breakdown of tyrosine and phenylalanine. The absence of this enzyme causes a buildup of homogentic acid, which can polymerize and deposit in connective tissues, leading to ochronosis, degenerative arthritis, and potential cardiovascular complications. While alkaptonuria impacts the metabolism of tyrosine, it does not render any additional amino acids essential. However, monitoring and potential reducing tyrosine intake may help manage the production of homogentic acid. Although dietary measures alone are generally not sufficient, potential vitamin supplements, such as vitamin C, ascorbic acid, also known, may be used to decelerate the buildup of homogentic acid in tissues by promoting its excretion and possibly reducing oxidative damage from its deposits. Although vitamin C does not correct the enzyme deficiency, it may slow the progression of joint and connective tissue damage associated with this disorder. Scenario 3. A newborn screening reveals elevated phenylalanine levels, suggesting phenylketonuria (PKU), an autosomal recessive disorder characterized by a deficiency in phenylalanine hydroxylase, the enzyme that catalyzes the conversion of phenylalanine to tyrosine. Without this enzyme, phenylalanine accumulates along its toxic metabolites, which can cross under the blood-brain barrier, and cause severe intellectual disability, developmental delays, and other neurological issues if left untreated. Early intervention with dietary restriction is crucial to managing PKU effectively. In the context of PKU, tyrosine becomes conditionally essential because it cannot be synthesized from phenylalanine. Therefore, it must be obtained through the diet to ensure sufficient levels for protein synthesis and the production of neurotransmitters, such as dopamine, norepinephrine, and epinephrine. So, potential vitamin supplements. BH4 tetrahydrobiopterin, a cofactor of phenylalanine hydroxylase, may be beneficial in certain patients with PKU, especially those with milder BH4 responsive forms of the condition. BH4 supplementation can enhance the residual activity of the enzyme, thereby reducing blood phenylalanine levels. Additionally, tyrosine supplementation is essential to maintain adequate levels for normal psychological functions. Given the inability to synthesize it endogenously due to the enzymatic block in PKU. This 58-year-old woman has progressively worsened fatigue, generalized weakness, shortness of breath during physical activity, and neurological symptoms including numbness, tingling, and balance difficulties. Physical examination reveals pale conjunctiva, a beefy red tongue, and clinical signs suggested of megaloblastic anemia. Given her clinical picture, we need to investigate potential vitamin deficiencies that might be responsible for her symptoms, particularly iron, B6, and B12 deficiencies. As you can see in the picture below, some examples of what these deficiencies might look like and how they would present in a patient. Let's talk about iron deficiency. So iron deficiency is a prevalent cause of anemia, typically resulting in microcytic hypochromic anemia characterized by small pale red blood cells. The mean corpuscle volume measurement for microcytic anemia, microcytic anemia, is typically below 80 FLs. Common symptoms include fatigue, pallor, and occasionally cravings of non-food items, pica. However, iron deficiency does not usually present with neurological symptoms such as numbness or balance problems, nor does it lead to a beefy red tongue or megaloblastic anemia. As seen in this patient, since iron deficiency primarily affects the hemoglobin production rather than DNA synthesis, it is less likely to be an underlying cause in this case. So, vitamin B6 is essential for various enzymatic processes, including amino acid metabolism and neurotransmitter synthesis. Deficiency in B6 can manifest with irritability, depression, confusion, and seizures, along with a rare form of microcytic anemia due to the impaired heme synthesis. However, B6 deficiency does not cause megaloblastic anemia or severe neurological symptoms like those observed here. Moreover, B6 is not directly involved in purine or pyrimidine metabolism, which are critical for DNA synthesis, making it an unlikely explanation for her condition, as you can see below in the graph. Vitamin B12 deficiency is the most plausible diagnosis for this presentation. B12 is integral to DNA synthesis, particularly in the form of purines and pyrimidines. It serves as a cofactor for methionine synthesis, crucial for regenerating tetrahydrofolate, THF, a form of folate necessary for thymidine synthesis, a vital component of DNA. Without adequate B12, a functional folate deficiency occurs, leading to the impaired DNA synthesis and the development of megaloblastic anemia, characterized by large, immature, and dysfunctional red blood cells. The mean corpuscle volume is above 100 in cases of macrocytic anemia, like megaloblastic anemia. B12 is essential for maintaining myelin sheaths on nerves, and its deficiency can result in neurological symptoms such as numbness, tingling, and balance disturbances, as seen in the patient. B12 deficiency, also called elevated levels of homocysteine and methylmalonic acid, contributing to neurological complications. As you can see in the picture, it shows some examples of signs and symptoms of B12 deficiency. Mechanism of B12 deficiency in impairing purine and pyrimidine metabolism. B12 deficiency disrupts the methionine synthase pathway, reducing the regeneration of THF from 5-methyltetrahydrofolate. THF is essential for the synthesis of purines and thymidine, a pyrimidine, which necessary for DNA replication and repair. This impairment leads to the characteristic megaloblastic anemia, as cells, particularly red blood cells in the bone marrow, cannot divide properly due to the defective DNA synthesis. So let's talk about some laboratory tests and expected findings. To confirm B12 deficiency and distinguish it from other causes, consider the following tests. CBC typically reveals macrocytic anemia with an elevated mean corpuscular volume. Peripheral blood smear likely to show hypersegmented neutrophils and macrocytes, which are characteristic of megaloblastic anemia. Also, a serum vitamin B12 level, direct measurement to confirm deficiency. A serum folate level to assess for concurrent folate deficiency, which can also cause megaloblastic anemia but does not result in neurological symptoms. Methylmalonic acid and homocysteine levels both are typically elevated in B12 deficiency, with methylmalonic acid being particularly specific to B12 deficiency and useful in differentiating it from folate deficiency. Overall, the patient's symptoms, clinical findings, and anticipated laboratory results strongly indicate a vitamin B deficiency, which impairs purine and pyrimidine metabolism and leads to her megaloblastic anemia and neurological deficits. Rapid diagnosis and treatment with B12 are essential to prevent irreversible neurological damage and correct the hematological abnormalities. To wrap up this presentation, I'd like to acknowledge the references that I used for this information. They are listed here.